Hi everyone, I'm Dr. Priti Anand, and today I'll be discussing with you the RRR YouTube series for MRCOG Part 2 students related to SRH module. So stay focused and never give up, just starting with a small quote. So the first question is that you have to give the correct choice for the below questions. Okay, so in that case, what is the interpretation of the test? What do the statement in the last they say? You have to choose according to that. Okay, so she's a 20 years old woman, 12 weeks pregnant. With the dermatological department, she has come with an asymptomatic reddish brown rash over the palms and soles for 25 days of duration. Thorough examination revealed the presence of an erosion on vulva, also a mucosal patch on the hard palate. Her RRR test was done. The RRR test was non-reactive. Treponema pallidum hemoagglutination assay test was done, which was positive. We requested for a repeat RPR test with higher dilution and it became reactive. Patient was also checked for HIV status and she was found to be HIV positive. Why is RRR test negative? Now, in this question, they have very specifically asked you that she is a case of secondary syphilis, which is very much evident by her clinical presentation and her TPHA test being positive. But why the RRR test was negative? This is the question what they are asking you. Why RRR test is negative? What is your interpretation that why this test is negative? So this test is negative because of the prozone phenomena. What is that? When the patient is in immunocompromised state, the very high antibodies fail to form the antigen-antibody complexes. And thereafter, when you increase the dilutions, the titers become positive. Now, they have asked you that why RRR test is negative? It is because of prozone phenomena. In which condition it can be this condition can happen? It is in the patients who are immunocompromised and suffering from either secondary syphilis, priority, or early latent syphilis. Okay, so there is a difference between the answer based on what is the lead statement at the end of the question. Okay. Now, second question says a 32-year-old primipara is referred before painless delivery. Spontaneous onset of pain has been managed with the primary care facility earlier. The initial screening test at 12 weeks gestation was RPR and TPP negative. No abnormalities were observed at the time of her visit at 37 plus 2 weeks. Painless induration, ulcerative lesions were seen, and the blood test was performed because she was suspicious of syphilis. No treatment of syphilis has been received in the past. Her EIA test is positive, TPHA is negative, and her VDRL is also reactive. That is, it is positive. So in which condition this can happen? Now they are very specific that in which condition this can happen. So look, EIA is reactive and TPPA is also reactive. RPR or VDRL we can say is also reactive, but TPHA test is non-reactive in this case. Okay. So this patient may be a case of early syphilis where TPPA or TPHA is not yet positive. It can be a prior syphilis, but they have already mentioned there is no treatment of syphilis in the past received and no such history is there. It can be a false positive EIA test, and in any of these conditions, a repeat testing in 2 weeks for TPPA is required. Okay, so according to them, in which condition this can happen? It can happen in the case of early infection. Okay, I hope the question is clear. Moving on to the next step. Primipara, same condition, 12 weeks pregnant. She is having a spontaneous pregnancy and managed at primary care facility. She's received treatment for rheumatoid arthritis since 10 years now. She had a history of smoking, stopped after discovery she is pregnant. She had a panic disorders, bipolar disorders. The medication she stopped by her own when she came to know she is pregnant. Screen test for syphilis at 12 weeks was as follows. No abnormalities observed in other test results. So her VDRL is 1:18 and immunoassay is negative. What is the interpretation of the test? So you can she is not symptomatic for any syphilis symptoms. The test was merely done as a ANC profile check, which you usually do at the booking. And VDRL 1:8, more than 1:8 is usually considered as a positive test. So why her VDRL test is positive over here? So some conditions like rheumatoid arthritis, some viral conditions like mononucleosis, some drugs like procainamide, some conditions like rheumatic fever, lupus, or leprosy can result in the fall positive VDRL. Even for the Asians, the long history of any mainly seen with the tuberculosis also shows that the patient may have the false positive VDRL. So what is the interpretation of our test? The result says that it is a false positive VDRL test. Okay, so 32-year-old woman comes to the hospital, vulvovaginal and vaginal itching. She has a history of smoking, which she has stopped. She has developed this itching, which was diagnosed as candidiasis and was treated with the vaginal suppositories. She was using them, but the discharge continued. The treatment was refractory. She has similar episodes in the past, so she is now considered as a recurrent case. Vaginal swab sensitivity confirms Candida albicans, which is sensitive to azoles. Now, she has already used the vaginal suppositories of azoles, which is not helping her. And she is now a recurrent case. And she is not pregnant also. So, in this case, we can start with the oral fluconazole, 150 milligram, 3 doses, 72 hours apart, and once a week for 6 months. Same patient who has been treated with the vaginal suppositories, now vaginal culture shows Candida albicans, but it is resistant to azole. So any patient who suffers from Candida albicans recurrent infection where it is found to be resistant to azoles, the next line of treatment is nystatin passeries to be taken in a dose of 1 lakh units intravaginally for 14 nights per month for 6 months. So there is a little difference between the non-Candida albicans, which are azole resistant, where you can use nystatin also, you can use boric acid also. Okay, that is an alternate, but the first choice is always a nystatin passeries. Where the azole resistant, nystatin basically is the main choice. Now she is a pregnant lady with 13 weeks pregnancy and vulvovaginal candidiasis she is suffering from. What treatment you will recommend this patient? So for the patients who are pregnant, you can't give oral fluconazole. So clotrimazole passery is given to them. 500 milligram is the dose intravaginally 7 to 14 days, followed by once a week for next 6 months. Okay, because it is a recurrent case. Okay. So you in these questions, you have to see that the patient was taking some contraceptives which are missing. And she's concerned about the unplanned pregnancy. For each of the patients, select from the above list, the most appropriate advice you will give her. 23-year-old female teacher who is on low dose 20 milligram estradiol containing combined oral pills for the past 3 years. Unfortunately, she forgot to take 2 of her pills in the 3rd week of her pill taking. What is the advice? Now, whenever there is missing of 2 to 7 pills, we have to see which week of, because oral pills are taken for 3 weeks. So which week this happens? If it happens within the 1st week of starting the pack, it's a problem. Within if it happens in the week 2 or week 3, then how we have to manage it? So for week 3 patient, you take the most recent missed pill, rest of the pill at usual time, additional cover for 7 days. But even if there has been oopsie, you do not require these patients to give emergency contraception. Okay. Now here they haven't mentioned about any oopsie. So you need not to mention anything about the emergency contraception as well. Okay. That part also you should remember. So for patients who are missing of 2 to 7 pills in week 1, you have to give the most recent missed pill, rest of the pill at usual time, additional cover. And if there has been oopsie, then emergency contraception. For week 2, only EC is given, no EC is given. For week 3, only AC is given, no EC, but you have to, at the same time, as in this case, you have to omit the hormone-free interval. Okay. So take the most recent missed pill, remaining pill at normal time, finish the pack, skip the pill-free interval. But with this ongoing management, you have to give the additional cover for 7 days. 20-year-old Katie student using a 30 milligram ethinyl estradiol containing OC pills misses 2 pills and the 9 pills are left in the packet. Now, because 9 pills are left, that means the missing happened in the week 2. What to do? Take the most recent missed pill, rest of the pill at usual time, additional cover for 7 days. And even if there has been an oopsie, no EC is required. 24-year-old woman and her husband having an intercourse, condom tears. She is attends the family planning clinic 3 days later after the oopsie. She is worried that she will get pregnant because she do not want children for the next 5 years. She is asking for emergency contraception. She has just delivered Sarah 2 weeks ago. So what advice you would give her? So for the postpartum patients, they are usually protected from unwanted pregnancy for the next 21 days postpartum. Because she is only 14 days postpartum, she is safe in the safe zone and she do not require any emergency contraception. If there is a 36-year-old Ellie delivered 27 days back via cesarean section, otherwise fit and healthy, oopsie 48 hours ago, she's breastfeeding the baby and wants EC, what is the best choice? Now, because she's 21 days has already elapsed and she is beyond that. Now, if the oopsie happens, she requires EC after delivery. Okay. She's 27 days after cesarean. So as we know, copper coil can't be given after any term delivery for 28 days. So copper coil is out. Now you are left with the two things, either UPA or LNG. Because she's breastfeeding the baby, exclusively breastfeeding the baby, UPA is better avoided. Because if you are giving UPA, you have to avoid breastfeeding for the next 1 week. So the best choice for this patient is LNG, 1.5 milligram regular dose. 18-year-old woman attends the family planning clinic. She is very anxious because she had unprotected intercourse with stranger 2 days ago. She's worried that she'll get pregnant. Not able to come to the clinic before this. She has epilepsy for which she takes phenytoin. She's under day 13 of a regular cycle. She does not want coil contraceptive method, emergency contraceptive method that you will recommend to this patient. So coil, she's in the day 13 of her regular cycle. That is, she's pre-ovulatory. She does not want coil, which is the best option. So copper coil is out. Now she's on phenytoin, which is an enzyme inducer. So UPA and LNG, both the oral pills are not given with enzyme inducers. UPA 100% not given. But if no choice is left, because it is 48 hours after oopsie, so LNG can be given. But here LNG needs to be given in double dose because she is on the enzyme inducer. 26 years old woman with HIV positive status has given birth 8 months back. She is on efavirenz, which is again an enzyme inducer, wishes to have a discussion about the postnatal contraception. What method is reliable for this patient? So guys, efavirenz is an enzyme inducer. So CHC, POP and implants are out. They can't be given. Now we are left with DMPA and LNG IUS. So the patients who are HIV positive, because here CD4 count is not mentioned over here. So we consider that they have the good points. Good CD4 count is there. So for high CD4 count or accurate CD4 count in HIV infected patients, basically for anybody, better is not to give the coils and anything in the intrauterine as an intrauterine device. So if we see in this table, copper coil and LNG IUS are UCAMAC2, whereas DMPA is UCAMAC1. So UCAMAC1 is preferred over UCAMAC2. So DMPA is the correct answer over here. 22-year-old Asian woman has an intrauterine pregnancy of 7 weeks. She had a copper coil 44 months ago, which is still there in C2. Her pregnancy test was positive and copper coil threads are not felt, unfortunately. Transabdominal ultrasound shows a gravid uterus with single GSAC of 7 weeks gestation. Copper device is visible with the stem in endocervical canal. So thread is not there. After thorough explanation, she wants to continue the pregnancy. What is your next step? So in these patients in whom, if the thread is visible and she wants to continue the pregnancy, before 12 weeks, you need to remove the copper coil. Now, because threads are not visible, but still stem is there in endocervical canal, so you will be able to pull it out. In case the thread is not visible and the stem is also not visible, then it is very difficult to say what to do. It is an individual decision between the clinician and the patient herself. So for continuing the pregnancy, if it is approachable to remove the device, it is best to remove before 12 weeks. So you can remove the copper device today. You are going to prescribe combined transdermal patches to 15-year-old girl with cerebral palsy to cope up with the period. So what will be the best way to give them the combined patches? Okay, so usually for these patients who are having some challenges, whenever you are giving contraception, you give it for preventing them from unwanted pregnancy and for the menstrual hygiene purpose also, because they are not able to take care of themselves. And preferably whenever you give the group of combined hormone contraception, it has to be given continuously for 3 months. Then you can give the 7 days or 4 days hormone-free interval. So 9 weeks at least you should give the transdermal patch followed by the 7 days of withdrawal period. Okay. And the choice of contraception depends upon their condition. I remember one of the very important questions that such same patient, similar patient with some challenges were asking for the hysterectomy. Okay. So what is the best advice you can give them? For hysterectomy, look, they have to take the ethical permission. The court permission needs to be taken. Okay. You can't do hysterectomy just by the patient saying or the guardian saying. 45-year-old has been referred for amenorrhea. She has stopped having periods about 10 months ago. She is not in any regular medication. She uses condoms as a contraceptive. So it is a non-hormonal variety and she wants to discontinue it because she's amenorrheic now. So she's asking you your advice. So for all the patients who are less than 50 and they have a complete amenorrhea of 2 years, okay, and they are using non-hormonal contraception, they can stop it after 2 years of complete amenorrhea, okay, because it has been stopping her periods only for 10 months and she's using something which is non-hormonal, that is condom. She has to wait for next 14 months, okay, so she can continue condom for the next 14 months and then she can stop. If she was more than 50, then complete amenorrhea of 1 year is only enough and they can stop the non-hormonal. Whereas CHC and DMPA needs to be continued till 50. After 50, you need to stop them and change with implant, POP or LNGIUS if the patient wants to continue some contraception. If the patient is on implant, POP and LNGIUS system, at least till 50, they have to take it. After 50, if they want to stop it because they are amenorrheic, you can just check on with the FSH level. If it is more than 30, you can stop it, whatever she's taking 1 year from the test levels. Syphilis patient having penicillin allergy, mild allergy is there, asking for no or treatment option, and there is no penicillin in options. Okay. So for patients who suffer from syphilis, the best treatment is benzyl penicillin, we all know, but she's allergic, but she's mild allergic. So whatever they say in the guidelines is you can do a desensitization test and go for the benzyl penicillin again. But in case if she refuses for the test or if you do not want to go through that test, then it is better to give injection ceftriaxone daily for next 10 days. Some patients who are needle phobic do not want any kind of injection. In those patients, amoxicillin or probenecid can be used. For this patient, because it is mild allergy, so you can use ceftriaxone. If the patient do not want IM injections, then you can use amoxicillin or probenecid, specifically if they are severe penicillin allergy and unable to tolerate even the intramuscular regime. Okay, so penicillin allergy, better if it is okay, you can do a desensitization. Mild sensitivity is there, then you can try ceftriaxone. If she does not want anything as an injection, so you can go for amoxicillin or probenecid. Woman visits an antenatal clinic at 28 weeks. She has been diagnosed with syphilis. She wants to know when is the risk of congenital syphilis more. So ideally, if the patient is starting any treatment of syphilis in pregnancy, it has to complete by 30 days before the expected date of delivery. Before the delivery occurs, 30 days before she has to she has to complete the treatment. Then the baby is considered as the very low risk of congenital syphilis. So if the baby delivers within the 10 days of treatment completion, then the baby will be at high risk of having congenital syphilis. So the answer in this question is C. So usually the congenital syphilis birth plan is based on no risk babies, low risk and high risk. No risk definitely makes you understand the patient never had syphilis or patient has been adequately treated with syphilis before she got pregnant, who have never been reinfected. Low risk are who has received the treatment for syphilis during pregnancy, but complete treatment has been done. Titers are very low and she completed the treatment 30 days before the birth of baby. And apart from both this are the high risk. So according to the low risk, no risk, low risk and high risk, the babies are given the syphilis birth plan. High risk babies will require a monitoring as well as the treatment. Patient with HIV on antiretroviral drug has been started, HIV positive women, and she wants to know during the course of a pregnancy, how will be the viral load monitoring done. So once you start antiretroviral therapy, the first viral checkup is done 2 to 4 weeks after the starting of treatment, then once in each trimester, then at 36 weeks, then at delivery. 28-year-old, 38 weeks pregnant, is planning for delivery. Her viral load is less than 50. She is compliant for medication from 18 weeks of her pregnancy. What is the post-exposure prophylaxis of the infant? So again, here the babies are divided into low risk, very low risk, and high risk. So the mothers who have taken a card therapy for more than 10 weeks in pregnancy, viral load 4 weeks apart is less than 50, recent viral load is also less than 50. Those babies require monotherapy with zidovudine for 2 weeks. So this patient is fulfilling the full criteria of very low risk patient. So babies at very low risk, so zidovudine monotherapy for 2 weeks is enough. For low-risk babies, you have zidovudine monotherapy for 4 weeks, and the high-risk babies, you have triple drug therapy for 4 weeks. 26-year-old girl who is suffering from trichomoniasis, and she asked that about the treatment of her sexual partner. Sexual partner will be treated. So for how long they have to stop intercourse so that the couple does not suffer from trichomoniasis from each other. So after treatment completion, at least for 1 week, they have to avoid it. Okay. So should be treated simultaneously and should be advised to avoid sexual intercourse for at least 1 week and until they and their partner has completed their treatment and follow-up. 30-year-old, 34 weeks pregnant, is seen in antenatal clinic with PROM. She's HIV positive on the heart therapy. Viral load is less than 40. Cephalic presentation baby is there, and she is concerned about the vertical transmission of HIV to the baby. She wants to keen to avoid surgery if possible. Which of the following is recommended? So for either it is a spontaneous rupture of membrane at the term or premature rupture of membrane where the pregnancy is 34 weeks or more than 34 weeks. The patient with the viral load of less than 50 requires can undergo a vaginal delivery, and because the rupture of membranes has happened, it is a immediate induction of labor needs to be done. Because she is 34 weeks preterm, so GBS prophylaxis will be given. Otherwise, the treatment of these patients will be same like spontaneous rupture of membrane at term. So less than 50 vaginal delivery, but it has to be immediate induction. More 50 to 399, you can consider CS, and more than 400 or equal to 400, immediate caesarean section needs to be done. So thank you, everybody. I hope this session was helpful to all of you. Let's meet in another session time by time. And thank you so much, and hope this helps everybody. All the best for your exams. Thank you so much.